University, United Arab Emirates, and our deep condolences to them on the passing of UAE President. May he rest in peace. Okay, if there is any question during the presentation, you can send it to Muhammad Khalid. The username is in the last message in the channel. I hope you will enjoy and get benefit from our guests' massive experience. Okay, now we can begin the presentation. Unfortunately, the doctor having a technical problem, so we will conduct the presentation without him. The presenters can begin.
Hello everyone. This is a group of students from Al Ain University under the supervision of Dr. Asim. We will present our presentation that is titled about the pharmacist role in cardiovascular disease and tools of innovative paradigm. So due to connection issues, Dr. Asim unfortunately will maybe he will join us later. But now we will continue. This is the our co-presenters from Al Ain University, Abu Dhabi campus, for this symposium. Okay, hello everyone. This is Abdel Fattah Amir, a fourth-year pharmacy student from Al Ain University, and I will speak about cardiovascular disease and food. An unhealthy diet is a significant risk factor for cardiovascular diseases, as the Global Burden of Disease study cites diet as a major factor behind the rise in hypertension, diabetes, obesity, and other cardiovascular disease components. There are an estimated more than 500 million obese and close to 2 billion overweight or obese individuals worldwide. There is much controversy surrounding the optimal diet for cardiovascular health, and data relating diet to cardiovascular disease has predominantly been generated from high-income countries. But more than 80% of cardiovascular disease deaths occur in low and middle-income countries. Relatively sparse data on diet and cardiovascular disease exist from these countries through new data sources that are rapidly emerging. Modern food environments are more widespread in high-income countries than in low and middle-income countries, which facilitate unhealthy diets that are high in refined grains and added sugars, salt, unhealthy fats, and animal source food. It is low in whole grains, fruits, vegetables, legumes, fish, and nuts. They are often high in processed food and products light on whole food and fresh dishes. Following this diet can have a negative impact on one's health and can increase cardiovascular morbidity and mortality. Cholesterol level is an important measurement to be considered, as it is linked with a higher risk of cardiovascular disease. For example, consuming high levels of bad fat can lead to atherosclerosis and other cardiovascular disease. According to the American Heart Association, there are 4 major dietary fats in food: saturated fat, trans fat, monounsaturated fats, and polyunsaturated fats. Starting with saturated fat, which is also known as bad fat, this type tend to increase LDL, which is the bad cholesterol. Common source of saturated fats include animal products such as butter and meat, and processed foods like pastries and biscuits. Moving to trans fats, these fats are like saturated fats, tend to increase LDL cholesterol in the blood, but they also tend to reduce the good cholesterol HDL. So they are more damaging to our health and can increase our risk of cardiovascular diseases. Sources are manufactured food such as frozen pizza and microwave popcorn. And it also occurs naturally in some meats, butter, and dairy products. Monounsaturated fats are fats that have one double bond in the molecule. It lowers your LDL but doesn't affect HDL. Oils that contain monounsaturated fats are typically liquid at room temperature, but start to turn solid when heated. And an example of such oils is olive oil. Polyunsaturated fats are fat molecules that have more than one double bond, and there are two types of polyunsaturated fats, omega-3 and omega-6 fatty acids. These fatty acids are found in food from plants like soybean oil, and can also be found in the fatty fish. It decreases LDL and total cholesterol by 8% to 12% when compared with saturated fatty acids, and it improves triglyceride and HDL levels. To speak about morbidity and mortality, a study formed in 51 countries in the European region from 1990 to 2016 highlights the relationship between single dietary risk factors and cardiovascular diseases. Dietary risks were associated with 2.1 million cardiovascular deaths in 2016. In terms of single dietary risk, as we can see in this graph, a diet low in whole grains accounted for approximately 429,000 deaths, and followed by a diet low in nuts and seeds accounted for 341,000 deaths. And a diet low in fruits accounted for 262,000 deaths, and a diet high in sodium accounted for 251,000 deaths. And also a diet low in omega-3 fatty acids accounted for 227,000 deaths. Furthermore, in 2016, approximately 6,001 deaths occurred among adults younger than 70 years. Compared to other behavioral risk factors, a balanced diet is a potential key lever to avoid premature deaths. That's all for me, and my friend Muhammad will continue.
Thank you, my colleague Abdel Fattah. Hello, everyone. This is Muhammad Samir, a fourth-year pharmacy student from Al Ain University, and I will continue the topic further. Tips to be taken into consideration to reduce the risk of developing of cardiovascular disease. Next, please. As we see here, we have 4 points. The first point, limiting fried fast food and processed food is important as they contain saturated fats, which increase the bad cholesterol. They contain saturated fats, which increase the bad cholesterol. Second point, we have here, use the herbs and spices to flavor food instead of adding salt, as it is linked to the hypertension, which can increase your risk of heart disease and stroke. Third point we have here, choose the healthy fat containing foods such as nuts, seeds, avocados, olive oils, and their oil for cooking. Do not consume full-fat dairy products as they are rich in the saturated fats. Instead, a reduced fat dairy product can be used. Next, please. On the other hand, we have here a healthy diet focuses on the 5 major food groups. The 5 food groups are, we have here vegetables, and fruits and protein and grains and dairy. These food groups are determined by the U.S. Department of Agriculture, and the USDA guidelines are helping individuals maintain overall health. First, here we have vegetables, raw or cooked, and vegetable can be used as a snack food or as a part of lunch and dinner. Salad vegetables can be used as a sandwich filling. Vegetable soup can make a healthy lunch. And here we have the fruit. It is easy to carry as a snack and can be included in the most meals. Try to eat a banana with your breakfast cereal. And we have here a large orange and eat large strawberries. Can be a good snack between meals. In addition to that, we have here the protein group is the one of the more diverse food groups. And the USDA recommend eating variety of food from this group each week. And we have here the protein food groups contain animal-based protein and the plant-based protein. We have here the meat and chicken, fish, beans, nuts, and legumes. These all can provide protein. Moving to grains are any food made from wheat and rice, oats, cornmeal, barley, or other cereal. Example are we have here the bread and the pasta and the rice and the oatmeal. That brings us to the dairy group. According to the USDA, all fluid milk and foods are made from dairy that has a similar calcium content count as dairy. Here are some examples of dairy food and their cup portion equivalent. 1 cup of milk or soya milk, 8 fluid ounces of yogurt. This equal to 236 milliliter and 1.5 ounces of cheese, which equal 42.5 grams. And that's it for me and my colleague Abdel Fattah. Thank you for listening.
Moving to the next presenter, which is Nusayb.
Thank you very much. Hello everyone, I am Nusaybat Al-Damouk, a fourth-year pharmacy student at Al Ain University, and I will be briefly speaking about some counseling tips for patients with hypertension, diabetes, and heart failure. Next slide, please. Now, starting with patients with hypertension, these patients should be advised to take their medications as explained by the pharmacist, including the timing, relationship to food, and any other advice provided, and not to take any OTC medications without informing the pharmacist about the hypertension medications they already take, just to make sure to avoid any drug-drug interactions or additive side effects. Patients should also be told to report any adverse drug reactions or medication side effects that occur to him to his pharmacist or the physician. Patients should be told to monitor their blood pressure regularly at home, and they should also manage the stress, and some helpful ways to manage the stress include walking or taking a bath. Patients with any sort of heart disease should maintain a heart-healthy diet, which should be low in sodium and fat, stop smoking if they are smokers, and exercise for 3 to 5 times per week. Now, going to diabetic patients in the next slide. So diabetic patients should also be taught about the healthy diet and all the other points mentioned earlier for hypertensive patients, but there are some extra points that are more specific for diabetes, like, for example, limiting the carbohydrate intake and limiting protein intake in the presence of kidney dysfunction. The patients should also be advised on the proper administration technique and administration size for insulin, if insulin is taken. Moreover, they should be told about the proper storage conditions for insulin, which is refrigeration at temperature of 2 to 5 Celsius. And the patient should also be scheduled for regular follow-ups to check on the progression and assess the retinal, neurological, and renal functions. Next slide, please. Now, going to patients with heart failure, those patients should get vaccinated against flu and pneumonia, since these diseases pose a greater danger on patients with heart failure because they impair the oxygen utilization, putting more pressure on the heart. Patients should also be taught to weigh themselves regularly every day before they eat or drink to check for sudden weight gain that may indicate fluid retention and edema. Patients should choose proper clothing and avoid tight socks or stockings that may slow the blood flow to the legs and cause clots. It is also preferred that patients with heart failure dress in layers so that they can easily remove or add garments as needed to avoid temperature extremes. Patients should also be told to report any new or worsening symptoms to their pharmacist or physician. Now let's go to the next slide to talk a little bit about the monitoring of cardiovascular disease patients. So patients with hypertension and diabetes should do self-monitoring at home. For hypertensive patients, they need to measure their blood pressure twice daily, once in the morning before eating or drinking, and once in the evening. This can be easily done using a sphygmomanometer. Patients should be advised to rest for a few minutes before doing their measurement and sit in a chair with both feet flat on the ground and back straight, place their arm at the level of their chest, and stay still while doing their blood pressure measurement. For patients with diabetes, a glucose measurement is done using a glucometer. Patients should be advised to wash their hands first, then insert a strip into the meter and prick the side of their finger with the needle provided. Then hold the edge of the test strip to the drop of the blood. Then the meter will display the blood sugar level in few seconds. Another type of monitoring also done for patients with diabetes is the glycated hemoglobin or HbA1c measurement that can also be measured using a special kit at home. Patients should wash their hand, prick their finger, and squeeze the blood. Fill that blood into the blood collector and mix it with the testing solution per the instruction provided by the kit, and place the sample into the A1C analyzer and wait for the results. Normal levels of glucose and HbA1c are mentioned in the table below, as you can see. So for diabetic patients, they should have a preprandial glucose level of 80 to 130 milligram per deciliters and a postprandial or after food glucose level of less than 180 milligram per deciliter and an A1C level of less than 7%. And that's all for my part. I'll leave my colleagues to proceed with the presentation. Thank you for listening.
Thank you, Dr. Nusayba. Moving to Dr. Aya. The floor is yours.
Hi, this is Aya Ahmed Saib, a fourth-year pharmacy student at Al-Ain University. I'm going to talk about counseling tips for patients with dyslipidemia and atherosclerotic cardiovascular disease. So moving to the next slide, please. Starting with dyslipidemia, I'm going to introduce a brief explanation about it. Low-density lipoproteins are atherogenic and represent a strong cardiovascular risk factor. Therefore, LDL cholesterol remains the primary target in lipid-lowering therapy. However, treatment of low high-density lipoprotein cholesterol and high triglyceride are options to achieve cardiovascular risk reduction beyond LDL. So moving to the counseling tips, let's list some of the important counseling tips that help in reducing the risk of developing cardiovascular disease associated with dyslipidemia. First counseling tip is eating a heart-healthy diet. From dietary standpoint, the best way to lower your cholesterol is to reduce your saturated fats and trans fat intake to less than 6% of daily calories and minimizing the amount of trans fat you eat. Reducing these fats means limiting your intake of red meat and dairy products made with whole milk. Choose skim milk, low-fat or fat-free dairy products instead. It also means limiting fried food and cooking with healthy oils such as vegetable oils. The second tip is becoming more physically active. A sedentary lifestyle lowers HDL cholesterol. Less HDL means there is less good cholesterol to remove bad cholesterol from your arteries. Physical activity is important. At least 150 minutes of moderate intensity aerobic exercises a week is enough to lower both cholesterol and high blood pressure. The third tip is quitting smoking if you are a smoker. Smoking and vaping lowers HDL cholesterol. Worse still, when a person with unhealthy cholesterol levels also smokes, the risk of coronary heart disease increases more than otherwise would. The last step is losing weight. Being overweight or obese tend to rise bad cholesterol and lower good cholesterol, but weight loss of as little as 5% to 10% can help improve cholesterol numbers. Moving to the second topic, I'm going to give a brief explanation about atherosclerotic cardiovascular disease. So the inside walls of healthy arteries, as you can see in the left picture, are smooth and clean. This makes it easy to transport the blood our body needs. But arteries can become clogged, as you can see in the right picture. Fatty substances like cholesterol can stick to artery walls. These deposits are called plaque. Plaque can eventually slow or block the flow of blood, and this blockage called atherosclerosis. Let's talk about some important counseling tips. So the first step is keep track your numbers. What I mean by keep tracking your numbers, several body-related measurements have been shown to correspond to atherosclerosis and heart disease risk. It's important to try to stay within recommended ranges of these measurements. The following numbers are important to watch. The first one is the blood pressure. An optimal blood pressure reading is less than 120 over 80 mmHg. Blood cholesterol levels. Fat can clog in arteries is a disaster waiting to happen. Sooner or later, it could trigger a heart attack or stroke. The third measurement, blood glucose levels, and the fourth is body weight. The second tip is be physically active every day. Then limiting alcohol and stop smoking if you are a smoker. Choosing good nutrition. The food you eat and the amount can affect other controllable risk factors such as cholesterol, blood pressure, diabetes, and overweight. Those nutrient-rich foods with vitamins, minerals, fibers, and other nutrients that are lower in calories. Emphasizes intake of vegetable, fruits, and whole grains, include low-fat dairy products, fish, vegetable oils, and nuts, and limits intake of sweet, sugar-sweetened beverage and red meats. So moving to the statins. Statins remain the first choice therapy, as they have been shown to reduce the risk of major vascular events by lowering low-density lipoprotein cholesterol. But a common side effect of statins and heart medications is muscle pain and damage. Moving to drug-drug interactions that may happen with statins, some drugs that may interact with the statins and increase the risk of developing side effects include imidazole, a medication for irregular heart rhythm, gemfibrozil, another variety of cholesterol drug, HIV treatments called protease inhibitors such as saquinavir and ritonavir, some antibiotics and antifungal medications such as clarithromycin and itraconazole, and last one is some immunosuppressant medications such as cyclosporine. That's me for today. Thank you for listening.
Thank you, Dr. Aya. Sorry for the technical issues.
Okay, hi, my name is Zainab Abdel Nasser. I'm a fourth-year pharmacy student at Al Ain University, and today I'll be speaking about a new interactive method used in learning. To begin with, I'll be giving an overview about what's meant by Kahoot, how to use it, and its benefits in learning. Kahoot is a free online game-based learning platform that can be used by any person with any device to create, discover, share, and play learning questions. First of all, you have to create an account and build up your quiz. The system will walk you through steps to add questions such as true, false, multiple choice, and puzzle. Also, videos and photos can be added, and then your quiz will immediately be available for use, or you can simply choose any of the already shared quizzes. Moving to step 2, the host will click play or launch to get a pen that has to be shared with the participants through their own devices. Then students will go to Kahoot.it website and type in the designated pen to enter the game. The question will appear on the host device or projector, and the participants will only have the color of the choice in their device. They have to answer as fast as they can to get a high score at the end of the game. Kahoot can accommodate more than 1,000 participants to play at once, so it's highly used in competitions. Moving on and addressing the benefits of using Kahoot, it's a new way of learning. Kahoot is a beneficial and outstanding tool used in today's virtual world of learning. It motivates students by creating a positive environment as it's a very energetic and lively platform. It reduces monotony and boredom as it encourages students to learn in a fun way. It's easy to use because only the host needs to create an account, while the participants can just type in the pen and enjoy the questions. Discussion and social learning, as it provides a positive learning outcomes by showing a great engagement from the student's side. And most importantly, it's a tool for assessment and competitions, without fear and stress in contrary to the traditional method of quizzes. This is highly applied at our university, as the photos below shows our experience using Kahoot to do in-class activities and a competition in Pharmacotherapy 1 course, and it was a highly successful event with positive outcomes. Last but not least, it increases student performance. The participation will be enhanced even among shy and quiet students. Here are some of the already shared Kahoot games. Feel free to scan any of the QR codes using your phone to check your knowledge about cardiology. Also, you can visit Kahoot.it website for more. Remember that using new learning methods is important to make people interested in improving themselves as healthcare professionals, students, or even as patients, as using Kahoot is essential to share knowledge, raise awareness, and save lives. Thank you.
Hello everyone, my name is Dana Albek, a fourth-year pharmacy student in Al Ain University, Abu Dhabi campus, and I'll be presenting about the 10 years risk calculation. The 10 years coronary heart disease risk scores can be calculated using 1. Framingham risk score, 2. The National Cholesterol Education Program Adult Treatment Panel 3 guideline, 3. Pooled cohort risk assessment equation, and 4. Reynolds risk score. Why do we have all these tools, and how do they differ from one another? Let's start with the Framingham risk score. It is intended for use in non-diabetic patients aged 30 to 79 years with no prior history of coronary heart disease or intermittent claudication, as it is the most widely applicable to patients without previous cardiac events. Risk is considered low if the Framingham risk score is less than 10%, moderate if it is 10 to 19%, and high if it is 20% or higher. It considers 6 coronary risk factors, including age, gender, total cholesterol, high-density lipoprotein, smoking habits, and systolic blood pressure. The National Cholesterol Education Program Adult Treatment Panel 3 guidelines advocates the use of a Framingham risk scoring system to estimate a patient's 10-year risk for a coronary event. Point scores are calculated according to the presence of 6 major coronary heart disease risk factors, with each risk factor worth a certain number of points. When added together, the sum yields an estimate of the risk for experiencing a coronary event in 10 years. A properly conducted assessment places patients into one of the 3 risk categories and forms the basis for all subsequent treatment decisions. Patients with documented CHD and CHD risk equivalents are automatically placed in the highest risk category, 10-year CHD risk of more than 20%. CHD risk equivalents carry a risk for a major coronary event considered to be equal to that of patients with established CHD. CHD risk equivalents include diabetes, peripheral vascular disease, symptomatic carotid artery disease, and abdominal aortic aneurysm. The LDL-C treatment goal for patients in this high-risk category is less than 100 mg per deciliter. In patients without documented CHD or CHD equivalents, assessment of CHD risk is essential to identify therapeutic goals. Patients with 2 or more major risk factors are considered to be at moderately increased risk for CHD, but with a 10-year risk of 10 to 20%. Therapy for these patients should be sufficient to enable patients in this category to achieve an LDL-C target of less than 130 mg per deciliter. Patients at the lowest risk are those with 1 or fewer major risk factors. In all but rare cases, these individuals have a 10-year risk of less than 10%, and the target LDL-C level in this group of patients is less than 160 mg per deciliter. For the pooled cohort risk assessment equation, it is a sex and race-specific tool for estimating 10-year absolute rates of atherosclerotic cardiovascular disease among patients without pre-existing cardiovascular disease who are between 40 and 79 years of age. Patients are considered to be at elevated risk if the pooled cohort equation predicted risk is more than or equal to 7.5%. It considers 9 risk factors, including gender, age, race, total cholesterol, high-density lipoprotein cholesterol, smoking habits, systolic blood pressure, whether diabetic or not, and whether receiving treatment for high blood pressure or not. And lastly, for the Reynolds risk score, it was designed specifically for women in an attempt to make the cardiovascular risk estimate more accurate. Specifically, the Reynolds risk calculator takes into account, in addition to other factors, a family history of premature heart disease, which implies a genetic predisposition to cardiovascular disease, and also CRP levels, a marker of inflammation. These 2 risk factors are thought to be more predictive of heart disease in women than in men. The Reynolds score is based on 7 risks including age, current smoker, if yes or no, systolic blood pressure, total cholesterol, high-density lipoprotein cholesterol, CRP level, mother or father with heart attack before age 60, yes or no. Notably, diabetes was not included in the calculation of the risk score. This is because people with diabetes are already known to have a very high cardiovascular risk, and using a risk calculator like this one adds little or no additional useful information. A similar study has now been conducted in men, and a separate Reynolds risk score has now been validated for men. Next slide, please. A recent study on the prevalence of cardiovascular risk factors and 10 years risk for coronary heart disease in the United Arab Emirates was conducted by Dr. Asim and several other doctors, where they have collected data from the patients and used the previous tools to calculate the 10 years CHD's risk scores. In their study, hypertension was defined as a blood pressure level of more than or equal to 140/90 mmHg, or taking any antihypertensive medications. Diabetes was defined as a history of diabetes or the use of glucose-lowering medications or fasting blood glucose of more than or equal to 126 mg per deciliter. Total cholesterol of more than 200 mg per deciliter, triglyceride levels of more than 150 mg per deciliter, LDL-C of more than 130 mg per deciliter, and HDL-C of less than 50 mg per deciliter were considered as risk factors for CHD in the study. Overweight was defined as BMI of more than or equal to 25 kg per meter squared and obese as more than or equal to 30 kg per meter squared. Lastly, physical activity is classified as metabolic exercise time. At least 30 minutes of moderate activity 3 days a week is considered as regular, 60 minutes per month as occasional, and less than 30 minutes per month as rare. Next slide, please. When each of the risk tools was applied to the study population, except those who are overweight and obese and less engaged in physical activities, all other subgroups showed a significant relationship, p less than 0.001, for the higher 10 years CVD's risk across the study subjects, Moreover, the pooled cohort risk assessment equation scale indicated a higher risk of CVDs among the older age population, while the Framingham risk score equation showed a mean risk score of 8.78 in men compared to women, 3.78. However, those who had high fasting blood glucose levels, hypertensives, and current smokers had higher risk scores compared to others. A significant proportion of the subgroups had at least one CVD's risk factor, and the majority of them are younger population, male, South Asian, and not engaging in physical activity. Moreover, more than or equal to 3 CVD risk factors were higher in men, 7.6%, and the younger population, 4.9%. Moving on to the next slide, the results obtained within the sample were as follows. The 10 years risk for CHDs of more than 20% was present in the National Cholesterol Education Program Framingham risk score with 7.1%. Yes?
Sorry, but the screen is not shared. Abdel Fattah, could you share the screen? Okay,
it is
now.
back.
Yeah.
Yes. So the results obtained within the sample were as follows. The 10 years risk for CHDs of more than 20% was present in the National Cholesterol Education Program Framingham risk score with 7.1%, pooled cohort risk assessment equation 2.9%, the National Cholesterol Education Program Adult Treatment Panel 3 1.4%, and Reynolds risk score 1.1%. There is evidence that clustering of risk factors confers higher levels of CVD's risk than each risk factor. Evidence from observational prospective studies suggests that a small effect of an individual risk factor on CVD's risk could be magnified in the presence of other risk factors. In other words, an individual with mildly abnormal levels of several risk factors often has a greater absolute CVD's risk than someone with a raised level of one risk factor. That is it from my side. Thank you for listening.
Good evening. My name is Razan Al-Mubarak. I'm a fourth-year pharmacy student from Al-Ain University. And in today's presentation, I'll be speaking about STEMI and non-STEMI score calculation. Let's know more about a story or a background about STEMI and non-STEMI, mainly focusing on calculating a score known as score calculation. GRACE stands for the Global Registry of Acute Coronary Events, and today we'll be focusing on a medical condition known as acute coronary event or acute coronary syndrome. GRACE was an international registry that gathered data from over 250 hospitals all around the world. The GRACE score is a scoring system which is used to risk satisfy patients with a diagnosis of acute coronary syndrome. The project enrolled over 100,000 patients with acute coronary syndrome and followed their in-hospital and long-term outcomes. Hence today, we're going to be focusing on patients that are in hospital in a period of 6 months to 3 years mortality based on their clinical presentation. This cooperation started in 1999 and resulted in an acute coronary syndrome calculator for assessing the risk and mortality among this kind of patients. About the main objective for today's presentation is to be able to use this GRACE calculator in order to estimate the probability of death, or let's say mortality, in acute coronary syndrome patient, as well as we need to determine the validity of the GRACE risk score as a determinant of immediate death during hospitalization for acute coronary syndrome, and also analyzing the percentage of cardiac deaths among a scale starting with low-risk groups, moving to intermediate, and finally with the high-risk groups. Knowing the difference between STEMI and non-STEMI is also crucial to be conducted in today's presentation because it's an important factor in order to conduct the GRACE score and get an outcome with a percentage of mortality and also a point of the GRACE score. Now, STEMI and non-STEMI. These two are branches, or let's say the acute coronary syndrome is divided into STEMI and non-STEMI. STEMI, it stands for ST elevated myocardial infarction, while the non-STEMI stands for the non-ST elevated myocardial infarction. There's also a third branch known as an unstable angina, but today we're going to be focusing on STEMI and non-STEMI. To know more about STEMI and non-STEMI, we can differentiate their definitions by saying that STEMI results from complete and prolonged occlusion of epicardial coronary blood vessels. On the other hand, non-STEMI usually results from severe coronary artery narrowing and also transient occlusion. Another definition, we can say that it is an elevation of the cardiac biomarkers in the absence of ST elevations. Now let's move to the second slide. Now let's talk about the main variables involved in Gray score. But first, let's know more about the Gray score. Gray score has been tested in more than 20,000 patients in multiple databases and is extremely well validated. The NICE guidelines also recommended that the Gray score is for risk stratifications for patients with acute coronary syndrome. Now, as we can see on the top left of the slide, there is a data that says that we have specific points starting from 1 to 69 points, 70 to 90 points, and also a mortalities. We can see when we start with 1 to 69 points, we have a mortality of less than 1, while 91 to 130 points, we will have a ranging mortality from 3.3 to 9%. And we can see a direct relationship is that as points increase, we can see increase in risk and mortality percentage as well. Now, these variables are involved in the Gray score, starting with age, moving to heart rate, systolic blood pressure, renal function, congestive heart failure, ST segment deviation, cardiac arrest, and elevated biomarkers. Now, let's talk about some of them and take examples, starting with the age of less than 40 years with a points of 0, while ages of 40 to 49 with a points of 18. What does these points mean? These points goes automatically with age, which is consistent with the higher risk of cardiovascular morbidity and mortality as well, among those who are greater than age of 60. So people with a greater age or an age of 60 will have a higher cardiovascular risk or mortality. Moving to the systolic blood pressure, we can see points of less than 79 are 24, systolic pressure of 80 to 99 are 22. Here, actually, we have the opposite, or let's say an inverse relationship. Interestingly, the systolic blood pressure, as we can see, the highest risk is among people who came with a systolic blood pressure of less than 80, which explains these patients may be in cardiogenic shock or may be hypovolemic as well due to their blood pressure, which is quite low. Gray score involved 90 hospitals in 14 countries, which had started in 2004. As we can see on the, let's say, right bottom of the slide, multinational studies of ACE patients, acute coronary syndrome patients, reported that the difference between mortality percentage in STEMI patients and non-STEMI patients in a period of 6 months, we can see clearly that non-STEMI patients have a much higher mortality compared to STEMI patients. That explains the importance of following these patients with acute coronary syndrome, being STEMI or non-STEMI. On an ongoing basis, watch for their symptoms. Try to further stratify them to interventions or medical care. Moving to the next slide, let's do a field test, because today our main, let's say, focus on using the MEDCAL to calculate the GRACE ACS score. You have the link. You can either use the link to have a direct access into the calculator, or scan the QR code available in front of you. Now we can take an example, starting with a patient with an age of 70, a heart rate or a pulse of 80 beats per minute, systolic blood pressure of 80 as well, and a creatinine of 2.1. We can see clearly as a result, there's a 30% of the mortality compared to 166 point of a race score. Now, how about we take a patient with a younger age of 40, a heart rate of 70 and a systolic blood pressure of 128 and a creatinine of 1.0 milligram per deciliter. We can see clearly that the mortality drops to 1.6% with a total of 71 points Gray score. Now, let me conclude this presentation by recalling the main goals achieved successfully today. Hope so. The first goal is that we differentiated between STEMI and non-STEMI. Also, the second goal, we successfully know the main factors involved in Gray score calculation. And finally, the third goal by which we shed light on it in today's presentation is to be able to use the mortality ACS calculator to calculate the Gray score in a form of points and to calculate the mortality in a form of percentage. That's the end of my presentation, and I hope that you enjoyed it. Thank you.
Good evening. I am Khawla Abhed, a fourth-year student at the College of Pharmacy at Al-Ain University. I will be discussing some aspects of CHADSVASC Score along with my colleague Noor Dabba. The CHADSVASC Score is a tool that predicts the one-year risk of a thromboembolic event in a non-anticoagulated patient with non-valvular atrial fibrillation. Now, patients with non-valvular atrial fibrillation suffer from an irregular and often very rapid heart rhythm or arrhythmia that can lead to the formation of blood clots. Now, onto the next slide. The annual risk assessment is used to assess the likelihood of the patient developing an ischemic stroke, stroke embolism, transient ischemic attack embolism, as well as systemic embolism, all of which are characterized by the presence of an emboli. Now, the score takes into account multiple risk factors that are assigned points from 0 to 2 according to the risk they pose. Now, the first factor taken into account is the patient's age. If the patient is under 65 years, they are at no increased risk and are assigned 0 points. If they are between 65 to 74 years old, the risk is heightened and they are assigned 1 point. A patient 70 years old or more is at high risk and is assigned 2 points. Another factor taken into consideration is the patient's gender. A patient who is male is at no increased risk and are assigned 0 points, while a female patient is at heightened risk and is assigned 1 point. Patients with congestive heart failure, hypertension, vascular disease, or diabetes mellitus history are assigned 1 point for each disease, as they heighten the risk of thromboembolic events occurring. If the patient has had a history of stroke, transient ischemic attack, or a thromboembolism, they are given only 2 points regardless of whether the patient has had more than one of the aforementioned diseases. Now, my colleague Noor Dabba shall delve deeper into the analysis of CHADSVASC Score. And thank you for listening.
Thank you, Khawla. That was a very fruitful presentation. Hello, everyone. This is Noor Dabba speaking. I'm a fourth-year pharmacy student at Al-Ain University, and I'll be carrying on with the CHADSVASC Score. Following up with my colleague Khawla presented about, here are the score interpretations for the CHADSVASC Score. The general trend states that the higher the score, the higher the risk of ischemic stroke and systemic embolism. But what does the score system actually mean? Score, which is 0, which means the patient is at low risk, but low dose aspirin is recommended daily. Patient score of 1 to 2 means that this patient is at moderate risk and this patient is a candidate for warfarin therapy. As if the score is greater than 2, which means the patient is classified in high risk and should be considered for warfarin or other anticoagulant therapy plans unless it's contraindicated. Next slide, please. But why to use the CHADSVASC score to begin with? The CHADSVASC score helps us with long-term stroke stratification for atrial fibrillation patients. Next slide, please. Something interesting to note about it is that it didn't actually start at CHADSVASC score. It started more than a decade ago when we were in search for user-friendly risk stratification scheme to predict the risk in two previous studies, the atrial fibrillation investigators and the stroke prevention in atrial fibrillation. They created something called the CHADS index, which takes its acronym from both factors and scores upon which it is based. It was widely adopted for its simplicity and broad applicability, to a point that you can even access it through MedCalc, which is a statistical medical software. But some investigators were concerned that the CHADS index failed to consider important factors that were later on supported by evidence to lead to greater risk of stroke or thromboembolic events in patients with atrial fibrillation. Therefore, a more accurate approach took place, which is the CHADSVASC score. The maximum score of the CHADSVASC score is 9, while it was only 6 in the CHADS score. This is because the additional risk factors were added to the new score system. Now let us see what are those additional risk factors in the next slide. Comparing the CHADS score and the CHADSVASC score, the latter was developed in 2009 after identifying additional stroke risk factors in patients with atrial fibrillation. But what are those additional risk factors? As shown here in the slide, the common risk factors between the two score systems are congestive heart failure and LV dysfunction, hypertension, age equal to or greater than 75 years old, diabetes mellitus, and history of stroke, while the additional risk factors in the CHADSVASC score are vascular disease, the age as well, but it accounts for 1 point if the patient is between 65 and 74 years old, while it accounts for 2 points if the patient is older than 75 years old. It also takes into account the sex category, as females have a higher stroke risk than males, which means if females with atrial fibrillation and no other risk factors, they are already considered at moderate risk in the CHADSVASC score. Next slide, please. That was all what we have for you for today. Thank you for your attention. We'd like to thank you for having us on this platform and giving us such opportunity. We, of course, would like to thank Dr. Asim, the leader behind everything we do. We'd like to thank the Deputy Dean, Professor Ghatas, for his endless support. We'd also like to extend our thanks to the Pharmacy Program Director, Dr. Bustanuddin, and also Dr. Abdullah, Ms. Dina. And of course, thank you to Dr. Sadim and University of Khartoum for such an insightful program. And thank you to the audience for your attention.
Thank you, Noor. Thank you for you all for this interesting and informative topic. In fact, cardiovascular diseases are the leading cause of death, so we should know how to deal with it properly. Now, the question part. Muhammad Khalid, you can start.
Assalamu alaikum wa rahmatullah. My name is Muhammad Khalid, and I will be presenting the questions that was sent to me by the audience. Actually, there is one question. A patient who has hypertension and uses beta blockers, then he developed a heart failure. Does the patient should continue the beta blockers or not, and why?
That's an interesting question indeed, thank you. But we suggest that this patient visits his own physician because other things and factors need to be taken into consideration before deciding upon his new or his existing therapeutic plan. Thank you.
Okay, thank you. There is no further questions.
Okay, thank you, Muhammad Khalid. It seemed like that Dr. Asim couldn't present with us, unfortunately. Okay, thank you for the presenters. We are really grateful for this nice opportunity. And I hope pharmacy students and professionals in Sudan conduct like this symposium nationally and internationally. And the audience, thank you for listening. Wait for us in another sessions, inshallah. And good night for all.